He's on administrative leave.
He's wearing a bracelet.
$500,000.
And I can take that.
Okay. Okay, so let's see how warm your hands are getting. Excellent. Keep working with those hands. Keep them moving. Lou, do we have any machines open?
Yes.
Yes? Okay.
It doesn't matter.
I grew up raising horses.
Science is over.
Yeah, I grew up started with
Good morning, everyone. Thank you so much for coming. I'm Leah with Medtronic. Medtronic partnered with the American Heart Association and the folks at Northern California Medical Associates for Heart Month this month. February is Heart Month, so you guys are all taking steps to reduce your risk factors and bring up your awareness and find out more about how you can be more heart smart today. So thank you all for coming. We do have some surveys here that I'm asking you guys to please fill out. And it's going to ask you some questions about your risk factors, just to help you start thinking about what are some things that you can do to make yourself less prone for heart disease. And Dr. Coleman, who I'm going to introduce in just a second, has been in the community here for over 20 years practicing at Northern California Medical Associates, and he's going to talk to you guys about those risk factors, awareness, and some of the things you can do to reduce your risk factors, and then some of the tests that go into how we find out what you've got and how we can treat it. So thank you again. If you guys have any questions, start thinking of some good questions that you can ask Dr. Coleman, because this is a great time to come in and have the full attention of your physician. A lot of times when you come into the doctor's office, you might feel rushed and not have a lot of time to talk about all the things you want. So this is a great opportunity to ask those questions and talk with your peers. So thank you again for coming, and Dr. Coleman.
Well, thank you very much. Thanks for coming out on kind of a dreary morning. As Leah mentioned, February is American Heart Month. The American Heart Association designates a month out of the year that we're really emphasizing and focusing on heart health. And as part of that, we're reaching out to the community, doing a lot of public service talks and things like this to make people more aware of heart disease and heart health. So this morning we're going to be talking about cardiovascular disease, and really this presentation is for people who are interested in learning more about cardiovascular disease. Coronary artery disease is one subset of cardiovascular disease, and I really want to emphasize that nothing really takes the place of sitting down with your physician and talking with them about your risk factors and about your heart health in general. And I'd just like to thank Medtronic for sponsoring the venue here and everything like that. They've been a real help and a real partner in trying to get the word out. So today we're going to talk a little bit about a description of cardiovascular disease. We're going to talk about how your heart works, how coronary artery disease happens. We'll talk about risk factors for coronary artery disease. There's things you can't control, things you can control. And then talks a little bit about the symptoms of coronary artery disease and then how we treat coronary artery disease. Cardiovascular disease is an umbrella term that talks about diseases of the heart and the blood vessels in your body, both arteries and veins. About 81 million people in the United States have some form of cardiovascular disease. That's about 1 out of every 3 Americans. So if we just took a sampling of the population, 1 out of 3 people in this room should have cardiovascular disease. Given the age ranges that I'm looking at, it's probably more than that. Coronary artery disease is a subset of cardiovascular disease. And coronary artery disease and stroke are the most common forms of cardiovascular disease. About 17 million people have coronary artery disease in the United States. As I mentioned, there are other subsets of cardiovascular disease that include stroke, hypertension, congestive heart failure or water on the lungs, peripheral arterial disease, and some people even group cardiac arrhythmias or rhythm problems under the heading of cardiovascular disease. Many of these they're not exclusive. Patients can have one or many of these different forms of cardiovascular disease. Fortunately, the treatment, or the causes and the subsequent treatments for this are much the same. Your heart is a very, very special and very cool organ. It is truly the workhorse of your body. It's the only organ in your body that fires automatically. Every other cell type in your body was waiting for a stimulus, but your heart does it on its own. It beats about 100,000 times per day, and it pumps blood to every single cell in your body. And that blood contains oxygen and nutrients and the ways to take the waste products away. To get to all of those cells, the blood travels about 60,000 miles each day throughout your body. That's the equivalent of twice around the world. So it really is a pretty amazing organ. The heart requires its own blood supply, its own source of oxygen and nutrients, and the blood vessels that supply that to the heart muscle are called your coronary arteries. And if those arteries are blocked or narrowed, then they can limit the blood flow and the oxygen supply and the nutrient delivery, and then your heart muscle doesn't work so well or can even die and turn to scar tissue. So it's very important that we keep your coronary arteries in good health. Coronary artery disease, as I mentioned, is the most common form of cardiovascular disease and develops when deposits of cholesterol and other materials occur in the vessel wall. And that deposition is called a plaque, a cholesterol plaque. You may have heard people talk about that. We can see here on the left side of the screen, this is a healthy artery. This is in about a 10 or 12-year-old. There's nothing in there. But as plaque develops, we get a narrowing of the heart arteries. And the real problem, and we'll talk more about this, is when that plaque ruptures and the toxic or noxious material within that plaque is exposed to the blood and forms a blood clot. And it's this blood clot that clogs up the artery and prevents blood flow down the artery and the delivery of the oxygen and nutrients. And the analogy I always use is this is my wife's hair clogging up the shower drain. It's the same kind of thing. So plaque buildup is called atherosclerosis. You've probably heard that term before. It's a Greek derivative, athero meaning paste, sclerosis meaning hardness. So that gives you an idea of this gritty, hard paste that's on the inside of that plaque. It's a slow, complex process, and it begins actually in our teenage years. Unfortunately, we know from autopsy studies from the Korean and Vietnam Wars that even young soldiers in their late teens and early 20s were beginning to show the early signs of plaque buildup. Again, this is bits of cholesterol and other material in the vessel wall, and it starts to narrow the artery, but the real problem is when that plaque ruptures. We used to think it was just the narrowing that was the bad actor, that it was more of a plumbing issue than anything else. But we now think that this is a complex, often inflammatory process in the vessel wall that occurs with age. The narrowing certainly can cause symptoms, but again, it's when that plaque ruptures, blood clot forms, and then that's what blocks the artery. That's why aspirin is so important. That's why when you go to the hospital, sometimes they will give you a clot-dissolving medicine in the setting of a heart attack. That's why we'll go in and open the arteries up mechanically in the setting of a heart attack. Over time, the narrowing of the arteries and the lack of blood flow delivery can damage, either transiently or permanently damage the heart so it doesn't function so well. And that can lead to blood building up in the lungs. That's called congestive heart failure. And if it actually kills the heart muscle, that can cause scar tissue to form. And that scar tissue is electrically different than the regular heart muscle, and that can lead to heart rhythm problems. So the problem with the coronary arteries can have a lot of downstream ill effects. There are a certain number of risk factors that increase your chances of developing coronary disease, and there are things that you can control and things you can't control. Can't control our age, wish I could. Can't control our gender. But there are other things that we can do that will help us control our risk of getting coronary disease, and those are mainly lifestyle issues. Obviously, the more risk factors you have, the greater the chance of you developing coronary artery disease. And this is where talking to your doctor can be very, very effective, because he can help you identify the risk factors that are unique to your own your own biology, your own personal health, and how best to modify those risk factors. The things that you can't control. Age. Nobody's found the fountain of youth. Genetics. There's a certain set of software that your parents gave you that predispose you to developing coronary disease. We all have heard of the lady whose cholesterol was 300, yet she lived till she was 99. Well, she had some genetic predisposition not to be affected by that high cholesterol. On the other hand, you hear about the 45-year-old who has a massive heart attack and dies. And he obviously did have a genetic predisposition, even if his cholesterol was relatively normal. Being male is a predisposing factor for coronary disease. Men have a greater risk of heart attack than women. Now, women's risk for heart attack goes up after menopause, so it's very important to think about that. But the actual rate of heart attacks, or the incidence of heart attacks, is greater for men than for women. What are the lifestyle things that we can control? Smoking is probably the biggest. This goes without saying, but if you haven't started smoking by now, please don't start. It's really unglamorous. High cholesterol levels, high blood pressure, diabetes, obesity or being overweight, and the concomitant part of that is physical inactivity. And certainly stress plays a role, but we really don't understand exactly what that role is. And it may be that it's just how each one of us individually handled stress that may be the biggest deal. What are some of the symptoms of coronary artery disease? Well, the most common symptom is something called angina or angina. And that's usually described as a pressure, heaviness, tightness, my bra is too tight, numbness, squeezing, fullness, usually located in the center of your chest, radiated out into your left arm, shoulder, neck, jaw, sometimes into your back, sometimes into your right arm. Those symptoms are the same for men and women. Other less common symptoms include being just short of breath, a racing heart rate or flip-flopping of your heart, something like a sewing machine is in your chest, a faster heartbeat than normal, dizziness or passing out, feeling like you're going to be sick to your stomach or vomit, just being suddenly exceptionally weak or profusely sweating just like you got out of the shower. Any of those could be symptoms of a heart attack. Coronary disease is the #1 killer of women in this country. And I see a lot of people shaking their heads like they've heard this before. And actually that's good, because we've been trying to get the word out. You could take the top 3 cancers that kill women, and breast is the #3 cancer that hurts women. Add them all together, that still wouldn't equal the disease or the death caused by coronary artery disease. So the biggest threat to women's health is coronary artery disease. Every woman has about a 50-50 chance of developing coronary disease over her lifetime. There are 8 million women living in the United States with coronary artery disease. That's equivalent to the entire population of Iowa, Nebraska, and Kansas. Now, what's very interesting is that there is a survival gap between men and women when they do have a heart attack. Remember I said more men have heart attacks, but more women die from those heart attacks. You could take about 6 football stadiums, fill them with women, and that's the number of women each year that have a heart attack. About 500,000 women have heart attacks each year, and about half of them, about 250,000, die from those heart attacks each year. So what are some of the symptoms for women? Well, it turns out that the most common ones are still that same symptoms of angina. The same squeezing, tightness, pressure, fullness, my bra's too tight, those kind of symptoms, the radiation into the jaw, throat, and arm. But they can have a much wider variety of symptoms. And it's important for docs to pay attention and listen and have their antenna up so that they can pick up on these things. They will end shortness of breath, the lightheadedness, the palpitations or the racing heartbeat. Sometimes it's just a vague discomfort in the upper body, heartburn, I've got a little upset stomach, the nausea, the fatigue, the sweating profusely, all of those things can be part of the symptom complex. And again, the chest pain or pressure, that's the same for men. Well, if you do have any symptoms of coronary disease, what's likely to happen? Well, you'll see your doctor, hopefully talk to him about what you're experiencing, and then he or she is going to order a number of tests, likely refer you to a cardiologist, send you to somebody like myself. And when they're listening to you, they're going to take into account a number of things. Your medical history and your family history. We talked about that genetic predisposition. They are going to look at your risk factors. Do you have high blood pressure? Do you have high cholesterol? Do you or did you smoke? And then they're likely to examine you, hopefully, and order a number of diagnostic lab tests, as well as perhaps some other tests and procedures to look for underlying coronary disease. So what kind of lab tests or blood tests might they look like? Well, if you came to the emergency room and were saying, I'm having chest pain, they're going to be worried about a heart attack. And so they're going to look for what we call cardiac biomarkers, evidence in the blood that the heart muscle has been damaged or hurt, and indeed there's a smoking gun there that says, look, this is coming from the heart. Other things that you might look for in the outpatient setting would be looking at your cholesterol or triglyceride levels. Those are lipid tests. Lipoprotein, homocysteine, and fibrinogen are markers of inflammation that may indicate that somebody might have a pretty normal cholesterol, but in reality they're at much higher risk for coronary disease. C-reactive protein is something similar. It's looking at inflammation, which we think does play a role somewhere in this whole process. They're going to look at the thinness of the blood, because certainly people who have or are prone to blood clotting or thick blood, they might have an increased risk of heart attacks. Blood sugar, looking for diabetes. B-type natriuretic peptide is a blood test that actually tells if blood is backing up in your lungs and your heart, and can give us a sense or a little bit of insight into whether your heart's working correctly. And then electrolyte tests and blood count tests, those are the standard things that doctors are looking at to make sure that your bone marrow and your kidneys are working okay. What are some common tests and procedures? Well, certainly an EKG, you've seen all of that. You probably had an EKG before. That's just an electrical signature of your heart. And it tells us how the wiring system is doing in your heart. And it tells us if you've had a heart attack before or not. Certainly, if you're having symptoms of chest discomfort or there are concerns about underlying coronary disease, then they're going to order an exercise stress test. And that's going to be coupled with either using a radioactive tracer that traces the blood flow in the heart, or looking at an echocardiogram, which is an ultrasound picture of how the heart moves when you're exercising. And if you can't exercise, then we have some medications that can trick your body into thinking that it's exercising and actually mimic the physiologic changes that happen with exercise. Sometimes we'll get a chest x-ray. If we're really concerned about underlying coronary disease, we'll do something called a coronary angiogram. And that's where we insert a thin tube either from the wrist or the groin up to the heart and inject dye into the heart arteries. And while we're injecting the dye in the heart arteries, we take x-ray movie pictures, and that dye will outline any blockages. And based on that information, we can say how many blockages somebody might have, where those blockages are located, are they severe enough to do anything about, and then decide if anything further might be necessary. What are some things, if you do have coronary disease, what are things that you can do? And this all goes back to looking at those risk factors that you can affect or you can modify. And they're basically lifestyle changes. We can eat better. We can be active. And again, stop smoking or don't start. That's a huge one. Lose weight. Probably the most important thing is know your numbers. Everybody here, I hope, has had an opportunity to have their cholesterol checked. Know what your blood pressure is. Know what your bad cholesterol number is. Know what your overall cholesterol number is. And then lastly, learn to relax. And by that I mean all of us have stress, but learn how to handle that stress in a positive or beneficial way. Your doctor may prescribe some medications for you. What are those common medications? We talk about antiplatelet agents. Well, platelets are little cells that travel around in your body. and they're the first part of that blood clot forming. Remember way back at the beginning of the talk, I talked about the blood clot forming and blocking the artery? Well, the very start of that blood clot is through these little cells called platelets. Well, aspirin is an antiplatelet agent. It puts those platelets to sleep. Some other common medications that some people might be on here would be Plavix or Brilinta or Effient. Those are also antiplatelet agents. ACE inhibitor and ARBs are a type of blood pressure medicine, but we don't necessarily use them just for blood pressure. We found that those types of medications can really improve the health of the lining of the blood vessels in your body. And remember we said that one of the problems with coronary disease was an inflammatory, complex problem in all the layers or all the lining of the blood vessel? Well, these medications can help improve the health of those blood vessels. Beta blockers and calcium channel blockers, likewise, were initially developed as blood pressure medicines, but we found that they favorably help the balance of how much oxygen your heart muscle needs versus how much it requires or burns to do its job, and they can help. Lipid-lowering medications are cholesterol-lowering medicines, and I would bet you that the majority of people in this room are on cholesterol medicines, and that's a good thing, because that's contributed tremendously to the decline in coronary artery disease and the death from coronary disease, because these medicines not only just lower the number, but they also make that plaque very hard and very stable so it doesn't break open, form a blood clot, and do bad things. And lastly, nitrates, that's like nitroglycerin. Those medications cause the blood vessels to open up and to dilate, so more blood, more oxygen can get to the heart muscle. Sometimes we actually have to fix blood vessels. We try not to if we can. We prefer using medications, but occasionally we have to fix blood vessels. And generally there are two ways we do that. The first is with a stent, and I hope or I bet that most people in this room have heard of a stent. It's a metal mesh-like cylinder like the Chinese finger puzzles we used to play with as kids that's crimped down on a balloon. We pass that through the blockage, then we blow the balloon up, and that balloon expands not only the balloon, but that stent, that metal, and then that metal acts as a scaffold or a skeleton in there and holds the artery open and increases the size and allows more blood and more oxygen to be delivered. Then your body does this neat trick where it grows a little layer of cells over that metal mesh so that your body no longer sees it as a foreign object. And then we obviously take out the balloon so that blood can get down there. The second way that we fix blood vessels is with surgery. And this is called coronary artery bypass grafting, CABG or CABG. And when that happens, the surgeon will use either an artery from the inside of the chest or veins from the legs. And what he does is reroutes the blood flow around the blocked artery, just like a detour on the freeway. We tend to use bypass surgery when there are multiple blockages or there are blockages in very critical places. So if you have one or two blockages, we may use stenting. But if you have more than 3 or 4, then we'll probably resort to bypass surgery. So that's why you'll hear somebody say, I had a 3-way or a 4-way bypass. So in summary, coronary disease is very common. It affects roughly a third of the patients in this country. It's caused by plaque buildup, and then that plaque can rupture, causing a heart attack. The symptoms are usually chest discomfort in the center part of your chest, radiating up into your shoulders or jaw. And these treatment strategies revolve around lifestyle changes, medications, putting stents in, and sometimes even surgery. So these are some places where you can get more information about coronary disease. The American Heart Association, there's Women's Health, the National Heart, Lung, and Blood Institute. All of these are great resources for the community. And there's some information on the back table. So I'll end there, and I'd be more than happy to answer any questions. Thank you very, very much for your time and attention. Yes? I actually think the answer is yes. The question was, can coronary heart disease or coronary artery disease be reversed? And I actually do believe that it can be. The problem is I think it requires such radical changes in people's diet. You almost essentially have to become a vegan. that most of us can't do that. We were raised on, scrambled eggs and bacon and potatoes for breakfast, and that's really hard to reverse after 60 or 70 years. There are clearly well-described examples of somebody dramatically changing their lifestyle and reversing their coronary disease. I absolutely believe that. I just think it's very hard for the average person to do that. Now, having said that, what we really want, if you've never had a heart attack, maybe even if you have, we just don't want things to get worse. So if we can keep things stable, we may not actually have to reverse it. And we can use medications, so the stenting, to keep things stable. Yes? ARB, angiotensin receptor blocker, and it's all in the same, the ACE stands for angiotensin converting enzyme, and basically those are some fancy enzymes, pathways in your body. Those medications do roughly the same thing, but they work at different points in this enzyme cycle. So they end up doing very similar things. Yes?
Your controversy around diet, especially eggs. Are eggs good for you or bad for you?
I think, the question was, are eggs good for you or bad for you? I think it's one of those in moderation kind of things. And I certainly think that if you tend to eat less of the egg yolks and more of the egg whites, if you want to have a 4-egg omelet, use three whites and 1 yolk, kind of thing, you'll be okay. Yes?
What are your thoughts on if you have coronary problems genetic-wise in families and both sides of the family and the cholesterol are higher, what are your thoughts on teenagers or your family members that maybe in their early mid-20s to be put on statin drugs or other things?
Oh, that's a great question. The question is, so you have somebody with a strong family history, elevated cholesterol, and you're talking about now starting teenagers or young people in their 20s on drugs. And the obvious concern is, it's one thing if you're 60 and being started on a drug because your lifespan may be 30 or 40. But if you're talking about somebody who's 20, they've got 70 or 80 years, and do we really want somebody on a drug that long? And my answer would be that it would have to be individualized, because there are certain familial genetic issues where you know that if you don't put them on drugs, that they will certainly have a heart attack, and if not likely be dead by the time they're 40. And so that kind of rare genetic familial hypercholesterolemia, that is an absolute. But there's going to be a much greater population where that's not the case, but yet they still have the family history, and they still have relatively high cholesterols. In that situation, I would try to do everything without medications. I would look for things that would prompt me to say, gosh, we do have to use a medication. One of those things would be some of the blood tests that we talked about, the C-reactive protein, to try to dice out who would benefit from drug therapy and who wouldn't. Another example would be to use a coronary calcium score. That's where you do a CT scan of the chest, and you're looking at the anatomy, but what you're really looking for is deposits of calcium in the blood vessel wall. Because when somebody who's 60 or 70 or 80 gets coronary artery disease, the very first step in that process is putting calcium into the wall. Your body does a very nasty thing. It takes it out of your bones. We all get osteoporosis, get hunched over, and it puts it in the blood vessel. And so the very earliest signs of coronary artery disease is the deposition of calcium in the blood vessel. So if at age 25 you can already demonstrate there's deposits of calcium in the blood vessel wall, that's somebody who I would say probably should be on medicines, because they've just now demonstrated they're not going to get coronary disease, they have it. Oh, you're way above my pay grade there. The question was, what about calcium and osteoporosis? That I wouldn't even begin to advise you on that. What I can tell you is taking calcium supplements doesn't increase the risk of depositing that calcium. Does not. So you're not going to hurt yourself You might get a kidney stone from the calcium, but you're not going to increase your coronary artery disease. You had a question?
Yes, and a lot of information out about coffee and wine effect on the heart. Do you have any opinion?
Yes, I think the question is, what about coffee and wine and the things that maybe we've heard are good or bad or good? Again, it's in moderation. I think that certainly the alcohol part of it turns out it's not necessarily a bad thing. Meaning, what we recommend would be 2 glasses of wine or one hard alcoholic beverage per day. That doesn't appear to increase your risk of coronary disease or cardiac problems. And in fact, when you look at population studies, the teetotalers, people who don't drink at all, they actually have a tougher time than the people who drink moderately, and that's the moderate part. People who are having 3 or 4 or 5 alcoholic beverages per day, that's probably not a good idea. And then there are some rare, talking about genetic susceptibility, there are some rare strains or rare types of cardiac problems that are made worse by alcohol that sometimes runs in the family. You'd certainly know about that if you had somebody, if that was a problem. Coffee doesn't seem to be a big problem. Now, the caffeine, though, if you have heart rhythm problems, which is a little different than what we've been talking today, but heart rhythm problems, the caffeine can cause a problem. So I would, if that's something that you're concerned about or you're having issues with, I'd certainly switch to decaf beverage. Yes?
What do you think the root cause is of the inflammation? Is it due to bad oral hygiene early in life? Having these bacteria starting?
No, I think you're sort of alluding to the oral hygiene idea. And the question was, well, what's the root cause of some of this? And I think it's a complex interaction between inflammation of the vessel wall that is not related to what happens necessarily at childhood. But I think it's genetic susceptibility, the environment, which includes your cholesterol, it includes your blood pressure, it includes your diet, it includes the things that we're exposed to, like cigarette smoke, whether you smoke or secondhand smoke. All of those play into the role. And it's all modified by your genetic susceptibility. You can have 2 people with both same environmental exposures, but one has the genetics where they have a problem and the other have the genetics where they're not that susceptible. Now, the question of the oral hygiene, dentists for a long time were telling cardiologists, we know who's going to have a heart attack because anybody that's got poor oral hygiene, they're going to have a problem. And we would just poo-poo that and we would kind of blow it off, and they were right. And probably the reason that they're right is because that's a marker of inflammation it's manifesting itself in the gums, but it's also occurring in other parts of the body, the coronary arteries. Any other questions? Yes, ma'am.
What is the average age of vascular stents?
Whoa. The question is, what's the average age of somebody who gets a stent? And I assume you're talking about a stent in the heart artery? I don't know that I know the exact answer. I would bet you it's probably somewhere in the 60s. But I mean, the youngest person I put a stent in is 28, and the oldest I've put in is under 100, I'm sure, but not by much. So it's a wide variety of patients who receive stents. Yes? The question is, where do triglycerides fit in all of this? And triglycerides are a precursor to cholesterol. And they're in your body, and they're dramatically affected by your diet. High triglycerides can be a marker of many things, but it's usually people have kind of a diet that's chock full of carbohydrates. And it's all the things that we like. I'm Irish, so it's potatoes, pasta, rice, bread, alcohol, cookies, sweets, fruit juices. All of those things are carbohydrates which increase your triglyceride levels. And then from a coronary artery disease standpoint, those triglycerides suppress the good cholesterol, and obviously if it's good, it's something you want. So it pushes the good cholesterol down and gets turned into eventually bad cholesterol. And so you really want to keep your triglycerides down. On top of that, if you have very high triglycerides, that can predispose you to other problems, particularly pancreatitis, which is this horribly painful thing in your stomach that's the worst thing that you can ever imagine. You never want pancreatitis. So, again, triglycerides primarily are diet, and the first step I have with somebody who's got high triglycerides is to talk about their diet, tell them it's a knife and fork problem. You don't need a medicine necessarily. Now, in rare cases, we will use medications when it's very, very high, but we tend not to. And the data really don't support that you make huge impacts by reducing the triglycerides and letting that good cholesterol come up. The data's not there yet. Thank you. Yes? Fish oil works. No, actually, yes, to a little bit degree. But fish oil mainly works by decreasing the triglycerides a little bit, but also by getting into the platelets and acting a little bit like aspirin in terms of being an antiplatelet agent. I mean, think about, well, where do we get all this fish oil business from? Well, let's see. We've figured out that Eskimos don't have heart attacks. Well, why is that? Because they eat fish oil. Well, where is that? Where's the connection there? It's that the fish oil also gets into the platelets, and it's like taking aspirin a day. The problem with some types of fish oil, and it really depends on which ones you have, they can actually raise the triglycerides and lower the triglycerides. By lowering it, it gets pushed into bad cholesterol, and your bad cholesterol can come up. And that's a well-described phenomenon. So you got to be a little careful. Anything else? Well, thank you again very, very much for your time and attention. I really appreciate the opportunity.